Assalamu alaikum, everyone. My name is Feras Namour, and today, alongside my Ibrahim, we'll be covering OSPE POD Part 2, the pathology and also pharmacology lab. So, the way that we're going to do this is we will go past all of your pathology lectures. We will be covering all the images and the things that are relevant for your OSPE. We will, for me at least, I will also give you kind of a pre-midterm pathology refresher, and then Maya will take it on hemodynamic diseases, neoplasia, and also she will be covering pharmacology lab. So let's jump straight into it and starting off with cellular adaptations. Now, just before we start, the way I usually arrange my slides is in the top right corner, I have the lecture. And so you can know what we're talking about, the reference. And the way I'm going to do this is with every lecture, we're going to have like a review for your info, just to refresh on some like pre-midterm pathology information for you. So like these don't usually come in the OSPE. They don't really ask you this in OSPE, but just briefly, we're going to discuss them. Of course, I'm not going to explain the whole lecture here. Cell adaptations. Essentially, what is cell adaptations? Now, these are processes happening due to cellular stresses, whether they are external or internal. The main purpose of cell adaptations is to prolong the cell's survival. Now, sometimes it's a physiological response. Meanwhile, other times, and most of the time, and our concern, it's a pathological condition. Now, we have 5 kinds of adaptations that we're going to discuss. Well, dysplasia, or like, all right, let's take it one by one. And now we're going to discuss 5 processes, okay? Starting with hyperplasia, which basically means increasing in number. Mashi, so this will happen only in cells that can divide. And we have 2 kinds of cells that can divide, labile cells and stable cells. Now let's take an example of liver cells that are stable cells. Now, if we remove part of the liver, now the other remaining part will grow itself, will grow the number of cells in order to compensate for the missed or like the removed part. So this is kind of an adaptation to a stimulus to keep the function of the organ, okay? And we will call this hyperplasia, increasing in number of cells. What about permanent cells, such as heart cells, such as brain cells? Can they do hyperplasia? No, because they cannot divide. They can't increase in numbers. They're permanent. So what they can do is hypertrophy, which means increasing in size. So we're not duplicating the cell. We're not making the cell number increase. We're just making it bigger and stronger and perform its function better. This happens in cells that can divide, for example, due to increased workload in the heart, or if one kidney got removed. So there's more stress on the other kidney in order to perform the filtration function. So the cells will hypertrophy, the glomerulus will hypertrophy, okay? هلا we have atrophy, which means decrease in size and function. It's kind of the opposite to hypertrophy. And metaplasia, which means changing from one cell type to another, right? And this happens at the stem cell level, and usually metaplasia is due to chronic irritation. All of these 4 kinds, we have histology slides, and this is what can come in your OSPE. So I just refreshed your information and familiarize yourself with all of them. And we're going to look at each, how it looks like under a microscope. And lastly, we have dysplasia, which will be covered in Maya's part more with neoplasia. But essentially, it's similar to hyperplasia, but this time around, it's increasing in number in a disorderly fashion. There's no order, there's no organization. Cells are just replicating and it's not under control. It could lead to neoplasia and malignancy. هلا starting with hyperplasia, remember how we said that we have physiological responses and pathological responses? So what's a physiologic hyperplasia? Well, it's breast tissue during pregnancy. When you have basically your breast tissue, when a lady is not pregnant, you don't have a lot of mammary ducts and glands. Like, as you can clearly see, the amount of glands, like your first glands, is very low. But when you have a pregnant lady, they multiply by a lot. They rapidly proliferate, and we have hyperplasia of the glands. And this is physiologic. This is not a pathological condition. This is just a lady, a normal one, that just became pregnant. What about BPH, benign prostatic hyperplasia, also known as nodular prostatic hyperplasia? And this over here is my normal prostate. Mashi? This over here is my BPH prostate. We can see the gland number here, the gland count here, and we can see a huge glandular count here. So we have increasing gland number, and there's a lot of branching of glands. and this is not normal. This could obstruct my urethra, right? So it's a pathological condition. So pathological hyperplasia is hyperplasia that doesn't normally happen. And we don't really know what causes BPH, but we know that DHT and estrogen facilitate further benign prostatic hyperplasia. And if we look even closely, we can see stratification of the epithelium. Usually the glandular epithelium should be one layer of cells, but we can see more and there's like piling on top of each other, there's stratification. And we know this is benign because there's a large or like large amount of cytoplasm compared to nucleus. All right, you know the nuclear to cytoplasm ratio. Now this will be like thoroughly discussed with Maya, but it's just like I added it here for cohesiveness sake, tamam? So we can see stratification in BPH, we can see a large glandular count, and we can see a lot of branching. And this is the same idea. We have endometrial hyperplasia. So again, it's a pathological condition. This is what the endometrium should look like normally, but we have so much more glands here, and it's problematic, okay? And it's usually due to unopposed estrogen. Some more examples, acromegaly, such as in growth hormone abundancy. And this is what your normal adrenal gland should look like. Over here, we have hyperplasia, which is basically just making the gland size much larger. طيب هلا in OSPE, like how will any of this come? Will you have to know that this is my prostate, this is my endometrium, and so on? You should know and pick, yeah, maybe it could come as a multiple choice, and you should know what I'm looking at. Is this hyperplasia? Is this metaplasia? Is this hypertrophy? And know the examples they provided you, okay? You're not a pathologist, you're not a doctor, but at this stage, for the bare basics, you need to understand histology a bit more than first year and be able to recognize the patterns. It's all patterns. Medicine is all about recognizing patterns. So if I see a lot of glands, I'm having hyperplasia. If I'm seeing cells in abundance, I'm seeing hyperplasia, and so on. When I'm seeing grossly, when I see something is enlarging, it's probably either hyperplasia or hypertrophy. And when I see it shrinking, it's atrophy, and so on. All right? Moving on to hypertrophy now. And the hypertrophy, as we said, usually happens to permanent cells. It can happen also to labile and stable cells, but let's stay in permanent cells. Our pathological example for hypertrophy is left ventricular hypertrophy, which is a cardiomyopathy. Now, this is your normal heart, right? It's small, and you have the left ventricle and the right ventricle. Usually the left ventricle is much thicker than the right, and we can clearly see that. But what do we see here? A much thicker left ventricle compared to the normal length, like left ventricle. So what's essentially happening here, because the heart cells can't divide, and there is a need for more pumping of the blood, there's decreased or like increased workload on the heart, we need to adapt. So how do we do that? Is through hypertrophy. Stretch mechanical signals will then stimulate cell growth. And because we can't divide, we'll just elongate more myofilaments, and we're going to induce this hypertrophy. All right. هلا thickened wall, we can see that clearly on gross. And if we look at the microscope, we can see this is normal, and this is the abnormal and thickened and hypertrophic cardiomyopathy. So you can see smaller nuclei here in normal heart tissue, but then large nuclei here in hypertrophic, and also the thickened muscle fibers and everything. Now, is this like, why is this a pathology? Why, if my heart is bigger and pumping more, like, why is this a pathology? First of all, it's a response to a pathology. There's increased workload. And second of all, look at the lumen here. There's less blood getting pumped. More volume is in the normal heart than the actual hypertrophied heart. So this is a pathology 100%. So just know the example, and it's hypertrophy. Now, a physiological variant for hypertrophy happens in pregnancy again. Now, a pregnant lady will have her uterus both hypertrophy and hyperplasia. It's going to increase in size and in number. This is what a normal uterus looks like, and this is a large uterus. We call it gravid. And this is the normal histology slide. And what do we see here? Large cells. Remember, this is the normal cell. You can know a cell from its nucleus and cell membrane. And then each one of these cells, they're very large and abundant in number. تمام? We could take this as an example for physiological hypertrophy. If you get this in the exam, this is not pathology. I want you to closely understand the pictures. And you kind of have to memorize most of OSPE يعني صراحة. But don't worry, OSPE in second year and POD, يعني it's nothing scary. It's going to be digital. Some will come as MCQ, some will come as short answer, or like you have to just name it. Inshallah, you got this. Now, if we're going to talk about atrophy, which kind of that is the opposite of hypertrophy, this is the pathological reasons. So if we have decreased workload, and it's called disuse atrophy. So let's say, for example, a coma patient, and they're sleeping all the time. They're not moving their body. They're not moving their muscles. Their skeletal muscles will atrophy because of the disuse. And if we have loss of innervation, it's kind of the similar idea. For example, in multiple sclerosis, like if we have reduced blood supply, if we have ischemia, it will also cause atrophy. If we have inadequate nutrition, hormonal stimulation, and so on and so on and so on. All of this is your pathology. This is not going to probably come in your OSPE. I'm just refreshing it. It's for your info. Now, the pathophysiology of atrophy is as follows. Because of all of these stresses, I'm going to have decreased protein synthesis. And then I'm going to have increased protein degradation. And then it's going to reduce my metabolic activity inside the cell. Ubiquitin proteasome pathway will overactivate, and it will accompany me through, it's going to basically cause a lot of increased autophagy, which is self-digestion and lipofuscin degradation, or sorry, not degradation, deposits. All of this is the pathological atrophy. And the physiological one is aging. As you age, your brain sometimes shrinks, your bones definitely shrink, your muscle, like you also waste some muscle. But that's the normal atrophy. What are the examples that you took of atrophy? You have kidney atrophy, and this is caused due to inadequate blood flow. So let's say you have your kidney and you have your renal artery, right? If you develop atherosclerosis in that renal artery, what will happen? Less blood will perfuse and go into the renal kidney. And then the renal kidney will not get oxygen, it will atrophy. It will be like less workload on it and it will slowly die away. So this is a normal kidney, and this is an atrophied kidney. You're going to see less cortical structures, less medullary structures as well. And the fat is what remains, the renal fat. Tamam? This is what you can describe here. These are some other examples that you were provided with. Yani, صراحة, these are low yield. Like you should more focus on the images such as necrosis and so on. But this is just for like you need to and you have seen these images at least once and you can kind of understand and guess what's going on. So this is adrenal atrophy. We saw what a normal adrenal gland should look like, and we saw a hypertrophied gland. This is an atrophied gland, and it's due to empty sella syndrome, which basically we don't have our anterior pituitary secreting ACTH, and it's not activating, it's not stimulating the gland. That's why the gland dies. You have testicular atrophy. This is a normal testis, and this is an atrophied testis, and it's due to cryptorchid testes, which means undescended testes, or Klinefelter syndrome, which is an intersex syndrome, complicated stuff you don't have to worry about. And this is brain atrophy. Usually, brain has not as much spaces here. These are very huge gaps. You're gonna see it in neuro better. This is probably due to Alzheimer's and other things. Now we talked about autophagy, and it's essentially the cells killing itself, like digesting itself. The way it works is you're going to have vacuoles fusing and lysosomal degradation, like gradual lysosomal degradation. And as it does that, as autophagy happens due to atrophy, everything in the cell will digest itself except for some lipids, and it will deposit as lipofuscin. So lipofuscin is my wear and tear pigment, as they say it. We can see it in multiple cells. Here is an example of a liver cell. And let's say we overwork this liver cell and it has to atrophy at some point. So it will digest itself except for these lipids, and they will deposit as lipofuscin. It's yellow-brown in color. Moving on to metaplasia. This is our final adaptation that we're going to discuss. Metaplasia is changing from one form into the other, right? So I have squamous cell here, change it to a glandular cell. Or it's the other way around. I have a glandular cell here, glandular cell here, change it into a squamous cell. The example that you were given is squamous metaplasia, and I'm going to explain it this way. I want you to look at the slide and tell me what cells you see. Here I have cells that are cuboidal, glandular, and so on. And then here, all of a sudden, I have squamous epithelium. So what's going on here? Metaplasia. All right. Do I need to know this is the cervix? Metaplasia. I have glandular epithelium, and all of a sudden, I have squamous epithelium. طيب, what does metaplasia mean like properly? Why, if I have squamous cells in the cervix, that's metaplasia? Because normally, you don't have squamous cells. Normally, in the cervix, in this slide, you should only have glandular epithelium. But for whatever reason, maybe there's an irritant, maybe there's a chemical, maybe some kind of ischemia or a chronic irritation, you have metaplasia changing the glandular into a squamous cell. Okay? And over here, I have my urinary bladder with its usual urothelium, transitional urothelium. You can see umbrella cells and it's stratified and everything. And all of a sudden, I see squamous cells. So what's going on here? Metaplasia again. So these are two examples that were given to you, and we have even more examples here. Usually, squamous metaplasia in the urinary bladder is a byproduct of schistosomiasis, which is a schistosoma hematobium infection. All right, so you took this in microbiology, just know it. It's a micropathology. Hello. Here I have the renal pelvis, ماشي? Usually in the renal pelvis, I see urothelium. But all of a sudden I have squamous cells and very stratified squamous cells. So this is not normal, this is abnormal. I should not have squamous cells in my renal pelvis, but I have it for whatever reason. So I have squamous cell metaplasia of the renal pelvis. And here I have something called glandular metaplasia. So in my esophagus, I usually have squamous cells. But in Barrett's esophagus, for whatever reason, I'm having glandular metaplasia. All of a sudden, I'm forgetting about my squamous cells and I'm just doing, what's it called, glandular epithelium. For metaplasia, for hypertrophy, for adaptation, because this is very broad. You're not studying renal, you're not studying endorepra, you're not studying GI. Just know the slides, know the examples that were given to you, and try to relate what's happening. If you see two kinds of epithelium, think, oh, probably metaplasia. All right. Cell injury. Now we finished from adaptations, let's keep going. Cell injury, to just briefly review what's going on, you have two kinds of cell injuries. You have reversible and irreversible injuries. Now, reversible injuries usually can go back to normal and you could easily regenerate it. Like when you heal it, it's through regeneration. But irreversible, you're going to heal it through repair and it will cause you a scarring. It will cause scarring, okay? Now, what is in our concern here is membrane damage. And we have three possible membranes that can get damaged. If my mitochondrial membrane gets damaged, I'm going to have failure to do failure of oxidative phosphorylation. Now, usually this is due to ischemia. I'm going to increase the formation of reactive oxygen species. More high conductance channels will happen. This will disrupt my membrane even further. I'm going to lose the membrane potential and pH changes. I'm going to have an acidic environment. This is going to disrupt it further. And most importantly, the release of two things. Mitochondrial protein, cytochrome C, which will activate apoptosis, and calcium will be released, activating ATPases, phospholipases, and proteases, which will activate the necrotic pathway. Now, necrosis is always pathologic. You should know that. But apoptosis could be either pathologic or physiologic, usually physiologic. Now, my plasma membrane could also be damaged, and my lysosomal membrane can also be damaged, and this will lead to crazy results in necrosis, specifically liquefactive necrosis. Reversible cell injury, you should know, or when you're looking, like, let's say you're looking at a slide, you should know that this slide is going through injury or not. How do you do that? Well, first you're going to compare it to normal, and then you're going to see what's changing. So in reversible cell injury, again, this is reversible, we have the following changes. We have hydropic change, which is cell swelling and vacuolar degeneration, and fatty change, which is going to be like appearance of lipid vacuoles in the cytoplasm. Here, I have kidney tissue, and One more thing, usually reversible cell injury is due to ischemia. So transient ischemia, not prolonged ischemia, so like ischemia for 5 minutes, depends on the tissue, of course. It can probably cause reversible injury because once blood comes back, once you no longer have ischemia, you're gonna go back to normal, right? So for reversible cell injury, over here, I have normal cells, and then I have cells that are enlarged, swelled, but they're still alive. I can see their nucleus, so they're still alive. So this is hydropic change. This is cellular swelling. This is due to reversible cell injury. Now, can I see the fatty acid change or like the fatty change? It's kind of hard to do. Let's mention it. If they show you this slide, you should mention both. Allah. This slide, I want you to memorize like your name. This slide comes all the time, and it's a tissue of the heart. And it's beautiful because it has all three stages of injury, normal, and death. Over here, I have normal heart myocardium. And I know it's normal because I see normal heart cells and normally sized nucleus. Each purplish, very small dot is a nucleus. Here on the other way, I am seeing some nucleuses, but all the cells are very enlarged and swelled. They have a lot of fluid inside them, a lot of cytoplasm. So what's going on here? This is my hydropic change. This is suffering from ischemia. And then this is dead tissue. Why is this dead tissue? I don't see any nucleus. So this image, when I see the middle part, I'm talking about reversible cell injury. I'm seeing hydropic change, and I also say fatty change. Now, ultrastructurally, which means if you look under an electron microscope, you're going to see blebbing, swelling, and nuclear clumping. That's all you need to know. Is it high yield for OSPE? Not really, but keep it at the back of your mind. Now, about irreversible cell injury. Now, irreversible cell injury will cause the cell to probably die, and then you're going to have scarring. And under a microscope, in order to know that a cell has permanently been damaged, it's going to have changes to the nucleus. Because if the nucleus is damaged, there's no coming back. So what happens is pycnosis, which is the nucleus shrinking in size, karyohexis, which is the nucleus breaking down, and karyolysis, which is the nucleus completely dissolving. Over here, I have normal size nucleus, and then smaller, very just tiny and shrunken nucleus. So you see the difference in size. This is pycnosis. And then my nucleus, after pycnosis, it will go through karyohexis, which is basically fragmentation of my already small nucleus. This is different than the neutrophilic segmentation. This is pathologic. And then karyolysis, where I don't see the nucleus anymore. And the cell will die very soon, probably through apoptosis. Now, let's talk about cell death. Allah. We talked about adaptation. We talked about injury, now death. So what happens if I'm having a stressor? It's going to cause my cell to try and adapt. If it doesn't adapt, it's going to get injured. And once it's injured, if it's permanent and irreversible, it's going to die in the end. And it does so by necrosis, and we have many different types of necrosis. Now you have the most important ones, which are coagulative, liquefactive, caseous, and fat. And then you have fibrinoid and gangrenous. You also have gummatous, but don't worry about it. Now, what's the appearance of necrotic cells? Most important thing, they don't have a nucleus. No nucleus, all right? The cytoplasm is very pink because of loss of RNA and binding of eosin, and there's loss of glycogen making it even more pink. So very pink cells and no nucleus. That's how I know there's necrosis going on. Let's start with coagulative necrosis. Now, why do we have different kinds of necrosis? What's going on here? Now, this is different than adaptations. Each adaptation happened to different causes and presented in a different way. Well, each one of these happen in a different place and they respond differently. They have a different like histology presentation and different mechanisms as well. So for OSPE's sake, we're not going to dive very deeply. We're just going to show you how it looks and how to answer your OSPE question. Like coagulative necrosis. It's mainly due to ischemia. And it happens in solid organs. So for example, the heart. In the heart, when you have ischemia, let's say you have an infarct, the cells will eventually die, right? You're going to have injury, but if the ischemia lasts very long, these cells can't do anything. They'll have to die. You're gonna not see any nucleus, and it's gonna be very pink eosinophilic. But what's special about coagulative necrosis? Essentially, like part of the pathophysiology makes for an intracellular acidic environment. And this denatures all of the lysosomal enzymes, making the cell to die and be like a corpse, like a body, like a preserved body. So I'm gonna have the outline of the cell. I'm not gonna have a nucleus, but the cell is still kind of there, but it's dead. So the nice thing about coagulative necrosis, well, there's nothing nice, but what's special about it is it preserves the cell slash tissue architecture. And this is going to be very important, like distinction point later on. And in a gross specimen, it's going to look like white patches, kind of like a scar, like, and as we said, under a microscope, it's going to look no nucleus and very eosinophilic, but the shape and the structure is kind of preserved. Meanwhile, in liquefactive necrosis, I don't have that acidic, like intracellular environment. So all of these enzymes, they're active and they're gonna just wreak havoc everywhere. If I look here, there's no kind of integrity, no structure, no cells, no architecture. I'm just looking at a mess. I'm just looking at a massacre. So liquefactive necrosis usually happens due to suppurative bacterial infection. So for example, Staph aureus, Staphylococci, and so on. It happens also in ischemic injury to brain tissue. So usually, if you guys recall, I said coagulative happens in solid organs. If your organ isn't as solid, it's going to have liquefactive necrosis. So for example, lungs, brain, both of these are soft tissue, so they're going to have liquefactive necrosis. And in a gross, not there's not much distinction صراحة. Like it's very dramatic as a histology slide looks like a galaxy and thunderstorms بس هنا يعني والله like there's nothing, there's barely anything. I just want you to be very familiar with every necrosis slide and every necrosis a gross image because they love to ask them. Okay, so please be very familiar with both of these for every necrosis subtype. And if we look at a microscope, besides that, there's no architectural preservation. If we zoom in further, we're going to see neutrophils. Of course, because we're talking about necrosis, we still have cells that are normal and alive. The ischemia didn't happen everywhere. So only where the ischemia happened, we're going to have a focus of necrosis. And around it, I'm going to have a barrier, like a boundary, separating the dead cells from the alive tissue. Is this preservation of structure? No. What do I mean by that? Because preservation of structure is inside the necrosis. Let's zoom in further. And as you can see clearly here, we can see our neutrophils. This is another example of liquefactive necrosis. We can see my neutrophils. And this is my necrotic area. Why is this my necrotic tissue? Because I see no nucleus. You see all of these dark purple dots? These are nuclei. Here, do I see any of it? Absolutely not. This is dead tissue. This is necrosis. What is this? This is coagulative necrosis. You see the architecture? This is liquefactive. So this is all dead tissue. And this is dead tissue as well. But it's just one big blob because it's liquefactive. It's a focus of necrosis. And this is the main difference between liquefactive and coagulative. This preserves the architecture because the denaturing hydrolytic lysosomal enzymes are denatured from the acidity. But in liquefactive, you don't have that acidity, and that's why it doesn't happen. And everything works here. Moving on to one of the most important necrosis types is caseous necrosis. Now, caseous necrosis is similar to liquefactive in the sense that there's no preservation, but it's a subtype of chronic inflammation. We're going to discuss chronic inflammation later on, but the most important thing here is that caseous necrosis is very commonly seen in chronic inflammation. And when you look at it at a gross specimen, this is again a lung tissue. You're going to see the necrosis foci, and it kind of looks like cheese-like appearance. Like I'm not sure. Maybe they were hungry or something. But It's disgusting, but they call it cheese-like appearance. So if you see this image, and I want you to memorize all these images very well, this is caseous necrosis, cheese-like appearance. You know? And if we go microscopically, if we look at it histologically, because we said it's chronic inflammation, we're going to have something called granulomas. Now, what is a granuloma? Basically, in chronic inflammation, when you're going to have a continuous source of irritation, it's going to kill tissue around it. So you're going to have a center of dead tissue, necrosis, and around it is going to be my inflammation. It's going to be my active war sites. So it will happen like macrophages will come here, they will become epithelioid cells, and then epithelioid cells will become giant cells, and it's a whole cascade. So we have this structure around the necrotic foci, which is called granuloma. I'm going to explain it later. Let's just set it up from now. So caseous necrosis, this is how it looks like under like a microscope. And Salaha, we're going to explain it later on. So we're just going to come back. Enzymatic fat necrosis is the easiest thing. Forget the reasons. When you're talking about OSPE, just know what normal fat looks like. The nucleus on the periphery, and you have the lipid, like the adipocytes in the center. And this is what it looks like when it's necrotic. Why is it necrotic? No nucleus. All right. Where is the single nucleus here? Nothing. And the lipid is died, like it's being taken up, it's dying, it's diffusing and everything. But this is enzymatic fat necrosis. Now, it usually happens due to pancreatic enzymes, such as, let's say you have trauma and the pancreas is damaged, it releases enzymes, or maybe acute pancreatitis, all right? That also causes release of enzymes. And when you look at it grossly, you're going to have this like chalk, like white chalk-like appearance. That's what they like to call it. That's a key word. Please remember that for pathology questions. And microscopically, as we said, no nucleus, lipid adipocytes, and it stains blue sometimes. Like there's a basophilic staining kind of going around. So if you look over here, like you see this bluish haze kind of. First of all, this is necrotic tissue. Why? No nucleus. Secondly, there's kind of a blue stain, but it's enzymatic probably. And you can see the adipocytes right here. And lastly, no, not lastly, you're going to have, let's move to fibrinoid necrosis, which is a very simple kind of necrosis as well. Now, from the name, fibrinoid, it's related to fibrinogen and fibrin, right? Hala, it's necrosis and it's caused by immunological injury. Hala, immunological injury means autoimmune diseases, most likely. So, for example, or like the examples that were listed for you were vasculitis. I think this was the purpura disease. Anyways, you're gonna study this in renal, and I just finished renal and I forgot about it. It's HSP basically, for like also rheumatic heart disease, vegetation, synovial tissue, and rheumatoid arthritis. Basically, antibodies against the body, autoimmune diseases. And this happens; these circulate all around. And the slide that they gave you is so easy because it's a vasculitis slide. And basically, this is a blood vessel. You can know it's a blood vessel because you can actually see RBCs going around. And around it, around this blood vessel, you have this fibrinoid, first of all, deposition and just inflammation and necrosis all around. So smudgy pink is infilic appearance, and it's pink because of the proteinaceous material within the tissue. We're going to talk about this a bit more in what's it called? Um, what was it called? Sorry. Later on, there was like a fibrous pericarditis slide. We're going to talk about it more there. But for now, just keep it at the back of your mind. Maybe we'll go back to it. Like gangrene. Gangrene. This is one of the scariest things you can ever see. Gangrene is a very special kind of necrosis because you have two kinds of it. You have a wet kind and a dry kind, and both of them are due to the result of ischemia or like loss, complete loss of blood supply to either the limbs or bowel segments. And the dry gangrene, which is the bottom picture right here, is essentially this form of loss of blood supply. It's an infarct, but there's no bacterial infection. Meanwhile, wet gangrene has an active bacterial infection alongside necrosis and possible blood supply loss. Now, in dry gangrene, you're going to see coagulative necrosis, and it's going to give you this mummified appearance. It's going to be literally hard to touch. And like the example they gave you was diabetic foot. Meanwhile, wet gangrene is going to present with liquefactive necrosis because, as we said, bacterial infection. So liquefactive necrosis, and due to the infection, you're going to have ulcerations, gas production, and even purulent material oozing out. And now we can talk about apoptosis because this is, I think, it sums up our cell death journey. So we've been talking about necrosis, which is external pressures on the cell and the cell dying pathologically. Apoptosis can happen due to physiological processes or sometimes pathological processes. Thus, if I'm looking at a slide, how can I know that this cell is dying through apoptosis? طيب, it's by knowing these microscopic features. And this is what is important for you in your OSPE app. I recall this came for us, so I'm not entirely sure. هلا, basically what first happens is the nuclear changes like pycnosis, karyohexis, and eventually karyolysis. What you're going to see as well is a nearby macrophage that is going to phagocytose the remainder of the cell, and the cell will slowly expend energy and just peel parts of it out by phagocytosis or like exocytosis and macrophage phagocytosing everything until there's nothing remaining in the cell. It's a very orderly, organized death. It's a very nice death for them. And there's no inflammatory response whatsoever. Actually, we have a special kind of like entity with them. It's called councilman bodies. And basically, you're going to see cells with their nucleus faintly dying out. You're going to have normal cells around, normal cells with their normal nucleus, and then cells slowly fainting out. And this is due to, again, pycnosis, karyohexis, and karyolysis. Well, now, this is a very, very weird thing that happened. They got us a question regarding the death pathways. Now, this is an OSPE review, and I don't have the time, unfortunately, to go through each individual pathway and enzyme and gene and so on. Best, I want you to familiarize yourself very well with them. So this is apoptosis, right? You have a phagocyte and parts of the cells are dying out, BCL2 members, and a lot of things going on, right? And this is the difference between necrosis and apoptosis. صح? Know these images, know these because they can come for you. This is the cell cycle P53. This is not like if a question came to you asking, out of all these three, which is the apoptosis or which is the cell death pathway, you should immediately say this one. All right? You should immediately jump on the back, BCL2, BCLX kind of train and get it immediately. Like, of course, they're going to hide apoptosis here. Okay, they're not going to show you that. But know these because it may come, it already came. And this concludes our Uban journey. It was a wonderful journey. God bless Dr. Uban. Let's move on to inflammation with Dr. Abrar. And once again, to freshen up your pre-midterm knowledge with inflammation, essentially, inflammation is our body's way to set things on fire. That's what inflammation means. It's our body's way to respond to any kind of foreign infections or foreign tissue damage or any form of tissue damage. It's a vascularized response, and it's intended to protect, defend, and heal the body. We have two kinds of inflammation. We have acute and chronic inflammation with different kinds of cells in both. And usually, inflammation is caused by infections, physical agents, chemicals, necrosis, foreign bodies even, and infections. Now, the cardinal signs of inflammation, you must memorize them like your name. Rubor, redness, hyperemia, calor, warm, also hyperemia. Dolor meaning pain. Tumor is the swelling and exudation. And functiolasa, which is like loss of function. They're just so extra with it. You should know these like your name. These will come. You can maybe they'll tell you to list them like the current symptoms you see. And these also are basics for your pro as well. When you get a patient, you should be able to at least identify immediately if there's inflammation superficial. And another like unique thing to inflammation is the presence of exudate. Now, exudate is basically edema or like extravasation of fluid with high protein. Now, why is that? Because you're going to have increased permeability, vascular permeability, like widening the spaces between the endothelial cells, allowing for fluid and protein to leave. So this is what we call exudate in comparison to transudate, which is only fluid. All right. So transudate is low protein. Exudate is high protein. It's very synonymous with inflammation. Let's talk about acute inflammation now. So what happens? What happens for acute inflammation? I have a sudden change in situation. I have a sudden infection. I have a sudden injury. I have a sudden death or like cell necrosis. So what's going to happen is a rapid response to deliver leukocytes and antibodies to the site of stress. Now I'm going to alter my vascular capabilities by vasodilating due to cytokines and also a whole kind of inflammation mediators. And I'm going to also increase my vascular permeability, as we just saw, which will cause exudation, exudate formation and edema, and my leukocytes to migrate from all over my blood to the site of the stress, because that's where I need them. And lastly, to even attract further leukocytes and so on, I'm going to have something called chemotaxis, which is going to be the chemicals that will attract leukocytes, neutrophils, and inflammatory cells, such as interleukin 8, complement, and leukotriene B. All of this is your pathology. This will not come in your OSPE because I want to refreshen up your memory, because understanding the process makes OSPE easy, makes everything easy. So what are the types of acute inflammation? You have serous inflammation, fibrinous inflammation. That's what I want to talk about with the fibrinoid necrosis. Suppurative inflammation, which can lead to an abscess formation, and ulcers. You also have catarrhal inflammation, which has a lot of mucus, hemorrhagic, blood, and gangrenous. All right. Now, I have this inflammation. What are the possible outcomes? Well, I have four possible outcomes. I can have resolution, going back to the normal state. The stress has been neutralized. Suppuration, maybe due to an infection. Repair. And if neither of these three work, chronic inflammation. I'm going to have inflammation go on longer than 48 hours. Now let's look at some acute inflammation, morphological changes. Over here, I have my normal lung tissue, capillary wall, alveolar wall, squamous cells. Life is good. What's going on here? I have vascular congestion, everything. And whoa, I have leukocytes now. Okay, and there's a lot of them. So this is acute inflammation. Maybe due to an infection, maybe due to bronchitis, pneumonia, whatever. So I need to just compare and contrast real quick what happened and the progressive nature of acute inflammation. So this is my increased permeability, and this is my extravasation. And these are more examples. Appendicitis is an example of acute inflammation. Now, your book said this is a neutrophil, okay, and these are some cells that are also synonymous with inflammation, such as mast cells. Acute inflammation, they will degranulize and send out histamines. Your neutrophil, hypersegmented neutrophil, and your monocyte. So all of these are synonymous with acute inflammation. I want you to know the slide for appendicitis. I want you to know the slide for alveolar infiltrate and congestion, and also the slide for mast cells. Let's go now and break down the four types of acute inflammation we just listed. So our first type, which is serous inflammation, is essentially a kind of acute inflammation which happens very superficial. It can happen due to, first of all, outpouring and exudating of fluid that could be from either the plasma or mesothelial cells lining, let's say, peritoneum, pleura, or even pericardium. And it's gonna do this layer of fluid underneath my epithelium. So it's gonna lift up my entire epithelium, and fluid is gonna fill up this newly made cavity. So there's going to be effusion, because effusion means accumulation of fluid in a cavity. And this is what we see in, for example, pleural effusion, in example, cardial effusion, and so on, and in blisters as well. So over here, I have a blister, and this is the microscopic view on it. So what did we say? We said the epithelium is entirely raised up, and you see this white area. This means there's fluid there, because there's nothing else there. And when you process the histology slide, fluid gets removed. So that's why you just see white stuff. هلا in MSI, you're gonna have a lecture called bullous disorder, and you're gonna enjoy it. It's all about this kind of thing. And what do we see here? Thank you. Redness, swelling, cardinal symptoms, rubor, maybe also pain. Thank you. All right, you should know these like your name. Fibrinoid inflammation is essentially when you have inflammation, but the vascular permeability increased so much that it's allowing fibrinogen to escape from the blood vessels and deposit into the interstitium or like anywhere outside the extracellular matrix. Fa, this happens, and let's like the example that you were given is fibrinous pericarditis. Do you guys remember how fibrinoid necrosis looked like under a microscope? It's kind of the same story here with the fibrin deposition. Pinkish, eosinophilic, but there's not really necrosis here. This is just deposition. You can still see some alive cells all around. Now, macroscopically, or yani on a gross image, it shows a bread and butter appearance because if anyone ate bread and butter and you took the butter and the bread, that's what it looks like, I guess. Like I think they were so hungry with this and the case's necrosis or something. This is zibda. Oh my god, zibda. I'm really sorry. But the microscope, another point to talk about is that there's no scarring whatsoever. So sorry. Then we're gonna talk about, and we finished two types of inflammation, right? We finished what's it called, fibrinous, and we finished serous. Now let's talk about suppurative, which is one of the most important infections. Now, suppurative is due to suppurative infections and purulent infections where they will release pus. What is pus? It's exudate, so it's high protein transcellular fluid consisting of also neutrophils, liquefactive necrosis, and edema fluid. Now, this happens in acute appendicitis, in lung abscesses, and of course, it's caused by pyogenic microbes, like most likely. Now, if you look at it grossly, this is the pyogenic or the suppurative inflammation. These are abscesses, and this is pus. All right. Whenever you see pus, it's an immediate marker of like suppurative inflammation. Now, this is an abscess that's being drained, and you can clearly see blood and pus coming out. Is blood a component of pus? No. That's maybe they also severed an artery or something. And this is how it looks like an abscess under a microscope. You can see some necrosis, some cells dying. There's no nucleus here. You can see some cells in the process of dying, small cells, pycnosis. And overall, an abscess is basically pus in a cavity. So you're going to see necrotic centers. You're going to see also liquefactive necrosis. And the examples you were given is lungs and also appendicitis. Now, this came in our OSPE. What came is this image and this image, and they asked for, I believe, lung abscess. Now, this is the lung abscess image, and this is the image of pus. Please, or like not lung abscess, they just asked for abscess. Please don't mistake this image for abscess. This is not an abscess, or like they will not give you the mark for it. This is, these are the images for pus, these are the images for abscess, and please memorize it. Necrosis, again, necrotic center, and yeah. Now, ulcer is something Dr. Abrar really enjoyed teaching. Like he really, I remember, he was very passionate about distinguishing between ulcers and erosions, and he'll do this again in MSI. Now, ulcers is essentially when you have trauma or any kind of stress or damage to an epithelium, and there's entire loss of the epithelium, like the whole thickness of epithelium is gone. So there's a disruptance of the continuity of epithelium. If we look over here, this is epithelium, right? And this is the other half of it. And then all of a sudden, there's like a bite taken out. And it goes all the way, all through the thickness. So this is an ulcer. This is not erosion or exoceration. Right? Now, the examples you were given for ulcers were peptic ulcers and diabetic foot ulcers. And an important complication is perforation. This is all your pathology. This is OSPE. So if they show you this image, don't want you thinking of an abscess. I don't want you thinking of like atrophy, anything. No, this is an ulcer. This is a peptic ulcer. And if they show you this image, it's the easiest image to ever see. You have epithelium, bite taken out of epithelium, ulcer. Tamam? So you're going to have necrotic debris. Actually, this is a very good example. This is the epithelium, this is the epithelium, this is the bite that's been taken out. So you're going to have the necrotic debris at the center, dead cells dying here. And then you're going to have inflammation, active inflammation, granulation tissue, which we're going to be discussing soon, and fibrosis. And over here, this would be our necrotic center, the inflammation, granulation tissue, and so on. Come on. Now, remember when we were discussing the outcomes of inflammation, of acute inflammation? What if the three fail? We're going to go into chronic inflammation. And this kind of inflammation is just prolonged, more than 48 hours. And it happens due to many conditions. And what you should understand at this stage is the following, is how it looks like under a microscope. I don't want you to know cholecystitis, gastritis, and all of that. I need you to know these things. So, chronic inflammation, what did we say about it? It's associated, or we see it also in caseous necrosis. What did we see there? Something called granulomas. Granulomas is the hallmark identifying feature of chronic inflammation. So we're going to discuss what a granuloma is in the next slide. But before that, this is how, like, what you're going to see normally in chronic inflammation. You're going to see, you're going to see these kind of inflammatory cells. You're not going to see macrophages or neutrophils. Sorry, you're not going to see neutrophils. You're going to see lymphocytes, plasma cells, and macrophages. You're going to see the attempts of healing and granulation tissue deposition. And also you're going to see tissue destruction and necrosis. So to sum up chronic inflammation in one way is that there is inflammation, there's injury, and attempts at repair at the same time. Like the big player here is granulomas, right? What is a granuloma? Once again, let's say you have an irritant that hasn't gone away. It's continuously causing these cells to die. Which cells? These cells in the center. So I'm going to have a necrosis or like a necrotic center somewhere. And this kind of necrosis is caseous necrosis. Now around this necrosis, I'm going to have macrophages that will differentiate into something we call epithelioid cells that will resemble epithelium cells, but they're macrophages. They're called epithelioid because they like lengthen and elongate. And then some of these epithelioid cells will merge together, forming a giant cell. You see a bunch of epithelioid cells merging together here. So we have multinucleated giant cells, and we have three kinds. And lastly, I'm going to have lymphocytes surrounding the whole thing. And this whole thing I'm going to call a granuloma. This came in our OSPE. This came and told us to identify the necrotic center and also describe some features about it. So you must know very well what you're looking. Like, what are the outcomes? What are the possible outcomes of chronic inflammation? We just talked about the outcomes of acute inflammation. But if this resolves by itself, we're going to have resolution and regeneration, some form of reversible injury. But maybe you're going to have repair and organization, like irreversible scarring injury. And sometimes it's indefinite. Like, what do you mean by indefinite chronic inflammation? What's like, there's an irritant, like it has to go away at some point, right? What if that irritant is made by your body? Antibodies, autoimmune diseases. That's going to be chronic, indefinite, like inflammation. That's what you see in rheumatoid arthritis. So again, what makes up a granuloma? The necrotic center, surrounded by epithelioid cells, and then giant cells, which are fused epithelioid cells. And epithelioid cells are originally macrophages, but then they differentiate. And then you have lymphocytes all around. Now, giant cells, this is what comes in your OSPE. It's very important because you have three kinds of giant cells. First of all, how do you identify a giant cell? You're going to see multinucleated, and it's very huge. Like, compare this to other cells, it's very huge. But yeah, these three types, how am I going to separate each one? By the position of their nucleus. If the nucleus is on the periphery, I'm going to have Langhans. If it's in the center, foreign body. And if it's on the periphery, but all of a sudden I have lipids around, two-ton. And this came in our OSPE. I think foreign body was the one we had. But please understand them, not memorize them. Langhans, periphery. Foreign body in the center. And two-ton, periphery, but there's also lipid around. Is I really hope this got across as much as possible. Here we have some examples of, again, this is like caseous necrosis because I don't see any nuclei here and it's liquefactive and we're going to have the epithelioid cells surrounding this necrosis. And these are some giant cells, right? Which kind? Periphery, so Langhans giant cells. And these are lying on the probably like the necrosis center, the necrotic center is probably somewhere deeper there. And to sum up our chronic journey, chronic inflammation journey, caseous necrosis and chronic inflammation both happen in TB patients. Mycobacterium tuberculosis. Mycobacterium tuberculosis, just it's like I think you guys studied it in your atypical lecture for bacteria. It's a very varied presentation, like microbe. What you should know is okay, if we have caseous necrosis, grossly it's going to look like cheese-like appearance. And if I'm going to look at it under a microscope, I'm going to have granulomas, I'm going to have chronic inflammations, lymphocytes, and so on. I'm going to have giant cells, Langhans giant cells, necrotic foci, and also all the epithelioid cells around it. So it's simple, it's easy. It's the stuff we just talked about. It's the stuff we just studied. Caseous necrosis, granulomas, cheese-like appearance, and large giant cells. The acid facet chain stain and Logis and Lostein Jensen media, and should be covered in your micro, inshallah. And to conclude with Dr. Abrar's beautiful image here for inflammation, heat, redness, swelling, pain. Don't ever forget the cardinal symptoms. Moving on to my final part, which is tissue repair. It's very straightforward, inshallah, don't worry too much. But basically, tissue repair is what happens after everything. So let's say again from the start, I have a problem. It's causing me stress. My cells are under stress now, so they're trying to adapt. Hyperplasia, hypertrophy, metaplasia, or even atrophy maybe. The stressor didn't go away, so acute inflammation is now involved. That didn't go away either. Chronic inflammation, and then lastly, thankfully, it got resolved. So now I'm gonna resolve it through tissue repair because there's already damage to my tissue and organs and cells. I need to repair. It's my body's way to heal itself. So before we can discuss tissue repair properly, let's just briefly go on the concept of stem cells because this came in the OSPE and I'm not, or maybe it was an MCQ, but I'm very surprised this even came. The stem cells, you have embryonic, like pluripotent, and you have adult stem cells, which are multipotent. By now, you are very familiar with these terms. Pluripotent gives rise to much more variety than multipotent. And you cannot find embryonic stem cells in adults, like people. We can call the stem cells somatic stem cells, and the examples you were given were two, liver stem cells and corneal stem cells. Now, the question that we got was an MCQ, I believe, and it's talking about the limbus. So just keep it in your mind. Maybe they show you an image. Just know about it. And for the liver, and I really doubt they're gonna get it. But just keep at the very back of your mind. Like, let's discuss tissue repair briefly and for your info, more than anything. So tissue repair, as we said, comes at the very end. Maybe it's a resolution to acute or maybe chronic inflammation. Now, it will involve restoration of the tissue architecture, and it depends on cell proliferation and also the extracellular matrix. Now, we have two kinds. We have regeneration, which is the healing of reversible injury, and we have repair, which is healing of irreversible injury. Like, what's the difference? Regeneration goes back to normal. There's no scarring involved whatsoever. Repair, on the other hand, is kind of like a compromise. Like I'm trying to just get it back as much as possible, and there will be scarring and just fibrosis of the granulation tissue. هلا, this concept we've talked about at the very start, which is different kinds of cells. هلا, when you're talking about proliferation and healing and so on, it's important to know which cells can do which form of healing. Can it do regeneration? Can it do repair? So, labile cells are the cells that are continuously dividing. For example, the cells of your buccal mucosa, the skin cells, and also your bone marrow cells. Stable cells, on the other hand, they can divide, but they only do if they have to. As we said in the liver, when my guy had half of his liver gone, the other half had to compensate and they grew itself again. This is hyperplasia of the liver. And it's a byproduct of stable cells. And permanent cells, which are the biggest problem, because they cannot regenerate. They can only repair. You can only do repair for permanent cells. So if you have a brain injury, if you have a nerve injury, if you have a muscle or even a heart injury, only repair through scarring. طيب regeneration can happen to labile cells and stable cells, but sometimes these cells also have to do repair. Why is that? And that we said something important is that healing depends on two things: cell proliferation and also the extracellular matrix. For the example of the liver that we gave, liver is a stable cell and it can like replicate. So it can do both. But when does it do this and when does it do that? Here we have normal liver cells, and here we have an injury to the cells, but the extracellular matrix is intact. But here it's not. So when I'm going to repair it, this will go back to normal through regeneration. But over here, I can't find something to regenerate. I can't find something to build on top because the extracellular matrix is crucial for you to build on top in healing. So unfortunately, because it was also disrupted, I'm going to have to do a scarring. I'm going to repair it by scarring, unfortunately. All right, this concept, I hope it's across. It's not really, yeah, it's not obvious. I wanted to just refresh in your memory with it. And now when we talk about repair or like healing in general, under a microscope, I could care less about regeneration. My whole focus is on the repairing and the scarring because that's what looks different and that's what I should differentiate from other like problems like necrosis and so on. So the process of scarring and repair is you need to make granulation tissue and you need to turn it into collagen. What is granulation tissue? Granulation tissue is our body's cement or like our tissue's cement to just heal. It's composed out of blood vessels, collagen, and also fibroblasts, which will secrete the collagen. And we have two kinds of collagen that will be crucial in the scarring process. We have type 3 collagen, which is more reticular and more like pinkish, let's say. And we have type 1 collagen, which stains blue. And this is what we're going to see in the scar, like the final stage. Now, what's my timeline? Because this is very important in healing. Healing happens over different days, and there's a timeline you should follow because morphologically, this changes. So let's say over 24 hours, I'm going to have my endothelial cells proliferating, my fibroblasts immigrating and coming to the site, and closing up whatever. And then from my days 3 to 5 or 2 to 7, I'm going to have deposition of granular tissue by my fibroblasts. And then weeks later, I'm going to have dense fibrosis. My collagen is going to change from collagen 3 to collagen 1, and it's going to form scar tissue, which is this blue, hard tissue. Now, repair comes in two fashions. We have first intention and second intention. First intention applies to small wounds and ones that can close easily. Meanwhile, if a wound is very large and irregular, that's going to be second intention. Let's discuss first intention first. Over here, I have maybe a slit cut. It's clean. It's regular. Let's say. Maybe I have a paper cut, something small. What will happen is the following: after 6 hours, or in the first 6 hours, I'm going to have a blood clot forming. I'm going to bleed a little bit. My blood will form a clot closing the opening, and then neutrophils will form. Neutrophils will be attracted through chemotaxis and will go there, and epithelium will regenerate. The whole thing will close. For first intention repair, the wound is closed in the first 24 hours, inshallah. for the most part. By then, from like days 3 to 7, we're gonna have some macrophages involved, like and also fibroblast proliferation. Now granulation tissue is deposited. Now collagen 3 bridges the incision, and lastly, my epithelium thickens because my epithelium regenerates, but it's a very thin layer. I need to like properly defend and thicken it up. And like after a week or so, a scar will be visible, a very small scar, and collagen 3 is remodeled into collagen 1, and my epidermis matures, and no more granulation tissue, no more. Only collagen 1 scar. No fibroblasts, no macrophages, nothing. So what about second intention? What about a very large wound or ulcers? Because ulcers also repair through second intention. We call it also secondary union. First intention, we call it primary union. But for now, let's just stay on topic. For this unfortunate lady, she had a large, I think, burn maybe. And all of this, the skin here and there can't just overlap and close by itself. You need to do a graft and so on. So what's going to happen here? Well, of course, first, you're going to have granulation tissue. So fibroblasts will invade the scene, and they will convert into myofibroblasts here, which will form actin and vimentin. But basically, the most important thing here, type 1 collagen will be converted into type 3 collagen. What usually happens is the opposite. But for the sake of the first stage, that's what's going to happen. And something specific that's going to happen is called wound contraction. This happens a bit later. And the example that you should absolutely know is how an ulcer heals. Because over here, you guys should easily call this an ulcer because of the epithelium break in continuity. Thus, how will this heal? As we said earlier, this would be necrosis, and then we're going to have inflammation and fibrosis and so on, granulation tissue. How will this heal? This will not stay open forever, right? Now, ulcers will heal by second intention. So granulation tissue will flood the scene, blood vessels, collagen type 3, and other things. And then hopefully and slowly, you're going to have both epithelium ends reunite. And wound contraction will happen, trying to narrow down the gap. How does the wound contraction happen? It's facilitated by myofibroblast as well. So what's special about first intention and what's special about second intention? First intention, you must know the timeline. You must know each phase and what time does it correspond on, and what does it apply to. So you have a scar by the end because this is repair. Both will have a scar. As this one will have a much irregular scar, and you're gonna have something called wound contraction. And for the most important slide for our repair segment, this always comes in the exams. I want you to be very used to this and comfortable with it. You have 3 abnormality scars, kind of like scar abnormalities. So the first one is, let's say, a lot of collagen is deposited into the scar, a lot of collagen type 1. So what's going to happen? The scar is going to stiffen, it's going to harden, it's going to have a hypertrophic look. So we call this hypertrophic scar. Like, what if the granulation and the scarring tissue, the collagen, it's produced, but it's out of proportion of the wound. It's not distributed equally and so on. And you have also a predisposition. This person is African American. This person arrests their collagen type 3 into type 1. They can't really form that link properly. You're going to develop something called a keloid scar. And you should memorize this image very clearly. It looks like what's it called? Like a kidney or something, okay? And this is how it looks like under a microscope. Like you can see, first of all, the very weird kind of granulation distribution, and also the epithelium is ragged and weird. So this image, if it came in your OSPE, it did multiple times in the past, immediately know it's a keloid scar. If the question presents you with an African American or even some kind of ear piercing and it's soft to touch, keloid scar. If it's hard to touch, hypertrophic scar. And our last unfortunate presentation is something called proud flesh. And it's basically my granulation tissue coming out and depositing everywhere, like outside my epithelium. It's so proud, it's showing itself to everyone, and it looks very weird, like fleshy. That's why they call it proud flesh. Now, granulation tissue, that is exuberant, that's another name for it. and I want you to memorize all of these three gross images very well. Now, the microscopic ones are lower yield, just keep them in mind. Come on. You can see clearly the granulation tissue outside. You can kind of see an epithelium and then like invasion of granulation tissue. And this concludes my part. So thank you all. Inshallah, yani, you have the very best PUD final. I know you guys are scared. I know you guys are stressed, but هون تعدي, and inshallah you guys يعني, you're gonna enjoy life after. Maya will take it away, inshallah, with hemodynamics and neoplasia. And I would just really wish you the best of luck. And thank you, Yasser, for helping me record this session and also helping me out with the slides. And yeah, Maya can take it away now.
Okay, so assalamu alaikum everyone. My name is Maya Ibrahim. I'm a third-year medical student, and I'll be doing the rest of the OSPE PAL today. We'll be covering hemodynamics, neoplasia, and lastly, we're going to be going through the pharmacology lab. I've looked through your past papers, and I've highlighted every text that is in green was included in your past papers before. So let's just get into it. Let's start with hyperemia. So hyperemia is an active process in contrast to what? Congestion. Congestion is a passive process. What does that mean? Hyperemia is usually due to two causes, okay? Physiological and pathological. Physiological, due to exercise. Pathological, such as acute or chronic injury. In this picture right here, it was probably due to a bacterial infection that caused inflammation and therefore release of histamines and then the dilation. So the dilation here is due to chemical metabolites, such as histamine. So there's increased blood flow to this area. In contrast to congestion, congestion is a passive process. What does that mean? It means that the blood vessel itself is not dilating, like there's not histamine acting on it, it's being pushed to dilate, such as in congestive heart failure. The blood goes back and pools in a certain area, causing the blood vessels to dilate. So that's congestion. Here we could see it in the lower limbs. This is probably due to congestive heart failure. And here you could see varicose veins, which are due to impaired valves, causing the congestion. Nutmeg liver is very, very high yield. I've seen it a lot in your past, so it's highlighted in green here. And this is usually secondary to congestive heart failure. So when a person has congestive heart failure, the blood pools in the liver, and this causes chronic passive congestion, which leads to hemorrhagic necrosis. So macroscopically, you can see a lot of blood everywhere, and then microscopically, you could see hepatocyte necrosis here, centrilobular, and you could see hemorrhage all over, and hematosiderin macrophages. Petechiae and ecchymosis are very, very similar. The only difference between them essentially is the size and the depth. So petechiae are little and they're superficial. So they can occur on the skin and they can occur in the conjunctiva in your eye. So they're small subcutaneous hemorrhage and they're usually due to platelet disorders. Ecchymosis is way larger, as you can see, and they're also they're deep. So they're large subcutaneous, it's a large subcutaneous hemorrhage. And they're usually due to trauma or problems with the clotting cascade or problems with the platelets. Moving on to pitting edema. Pitting edema is excess fluid in the interstitial tissue. So what makes pitting edema, and what makes non-pitting edema, non-pitting edema? When you press the skin of a person with pitting edema, it causes a depression that stays there for more than 30 seconds. Why does that happen? Because in pitting edema, the fluid that's in the interstitium is free fluid. In people with non-pitting edema, the fluid in the interstitium is due to protein-bound fluid. Okay, so when you press it, the fluid becomes displaced in pitting edema. When you press it in non-pitting edema, the fluid is not displaced because it's bound to protein. So it's kind of like heavier, if that makes sense. Okay, so moving on to elephantiasis. It's a parasitic infection. So filariasis due to Wickshieria bancrofti. This was mentioned in our anti-helminthes lecture, but I'm not sure if it's mentioned in yours. But I just added it here for the sake of completion. And it's a parasitic infection that affects the inguinal lymphatics, causing lymphatic obstruction. So obviously you would have something that looks like edema in this presentation. Orange peel appearance, this was also repeated in the past, that's why it's green. It's called peu d'orange, and it's due to carcinoma of the breast. Because just think of it this way, Carcinoma of the breast, it invades the breast tissue, right? What's also in the breast tissue? Superficial lymphatics. Superficial lymphatics are invaded by carcinoma. It would cause obstruction. So there would be edema in the breast skin. Moving on to fetal anasarca. Fetal anasarca. Anasarca means generalized edema all over the body, and fetal is fetus. So this is generalized edema with the whole body in a fetus. Now, these are other examples of edema. You have ascites, which is accumulation of fluid in the peritoneal cavity, pleural effusion, accumulation of fluid in the pleural cavity, and brain edema, which is accumulation of fluid in the brain. And this is a medical emergency, so when it happens, it could cause brain herniation, increase intracranial pressure, and finally death. Now, this is very, very important. I've seen it in SAQs as well as MCQs. Thrombus, lines of Zahan. In the thrombus, when you look inside of a thrombi, you could see little lines here, okay? What are these lines? They're called lines of Zahan, and they're successive deposition of platelets and fibrin. So the dark ones here are fibrin, and the light ones here are platelets. And these are usually seen in thrombi in places where there's rapid blood flow. So مثلا in the aorta, okay? Blood elements like the platelets, the fibrin, RBCs are deposited on each successive layer, and as it carries on, there's more and more deposition. So this is what it looks like, and this is what it looks like microscopically. And there was a past question that was like, hold on, let me get it. It was a 38-year-old man. He died, and then after an autopsy was done, it was found to have a thrombi. Which one of the pictures describes the case? And it would be either one of these pictures. Now, moving on to aortic aneurysm. Aortic aneurysm means an abnormal dilatation of the blood vessel wall. So you can see here that it's abnormally dilated, and it's normally due to like weakening in the wall of the aorta. And here we can see a ventricle after an MI. This is a thrombus that could be seen here. And an important point to mention is that thrombus can be formed due to a triad. And what is that triad? Verko's triad. Endothelial injury, hypercoagulability, and abnormal blood flow. Moving on to fat embolus. This was also in past. Fat embolus usually is associated with trauma, especially in the fracture of long bones. Why long bones? Because long bones have a lot of fat. So when there's a fracture, that fat becomes released, and it can occlude the pulmonary arteries. And you can see in this picture, the little circles here, the empty ones that look like empty circles, but they're actually adipocytes, fat. They occluded the pulmonary arteries. And this can be demonstrated by a Sudan black B on special staining. This is important because I saw this in an MCQ. They brought you this picture and they asked what type of staining can be used to demonstrate this. Okay, moving on to erythromatous embolus. Erythromatous, just remember atherosclerotic. So it has to do something with that, right? So there's an atherosclerotic plaque and something comes off of it, which is the embolus. This embolus is made up of cholesterol, crystals, and debris, and it breaks off and then occludes another vessel. And you can see it here, it has a fibrin and platelet thrombus. This is the F part. And the ones with stars here, you see these white stripes. Those are the cholesterol clefts. Now moving on to amniotic embolus. How does this come about? So it usually happens due to rupture of the amniotic sac or rupture of the uterine arteries. When there's rupture of either one of them, the amniotic fluid enters the maternal circulation. When it enters the maternal circulation, if it's due to rupture of the amniotic sac, it goes there via the uterine arteries and can occlude the pulmonary arterioles. As you can see here, they are packed with fetal squamous cells and they look like swirls, and the lungs would appear edematous and congested. Definitive diagnosis, you could see fetal hair, fetal squamous cells in the blood from the right ventricle. Moving on to pulmonary embolism. Pulmonary embolism is usually due to deep vein thrombosis. So it happens when a person is sitting for too long, blood is collected in the legs, results in DVT due to stasis, and then when a person gets up, muscles contracted, emboli, goes to the lungs and causes an embolism in the lungs. Now, this is called a saddle embolus because it's in the pulmonary artery branch and it kind of looks like a saddle. And this is an example of how the questions are. Which of the following is the most likely cause of a pulmonary embolism? A. Why A? Because we mentioned that in a fracture of lung bones or in orthopedic surgery where they would work with bones which have a lot of fat, that could break off and then go to the lungs, causing the pulmonary embolism. Okay, now moving on to red vs white infarct. What's the difference between them? Red infarct is usually venous occlusion. Venous occlusion, and the white infarct is usually due to arterial occlusion, okay? And venous occlusion usually occurs in loose tissue, while the white infarct usually occurs in solid organs. And it's also called anemic infarct. And red infarct is also called hemorrhagic infarct, okay? Okay, moving on to the last picture. Signs of sepsis. What is sepsis in the first place? I want you guys to answer this first because it's important. It's a life-threatening organ dysfunction caused by dysregulated host response to an infection. And this is a sign of sepsis, areas of mottled skin. This is how it would look like. If they give you an MCQ with a case that resembles sepsis and then they put this picture, you know what the answer is now. Now moving on to neoplasia. Neoplasia, the first thing we're going to mention is dysplasia. What is dysplasia? Dysplasia is reversible, non-neoplastic, disorderly growth of the epithelium. Now, it's not neoplastic yet, all right? It's reversible at this point. You can see here, normal cervical squamous epithelium, and then this is dysplasia here. Dysplasia is usually more in number, and there's hyperchromatism and pleomorphism. And the abnormal cells are only in the lower epithelium. They're not in the upper epithelium. How do we know that this is dysplastic? Because when we look at the top, the cells mature at the top and they look normal here. But when we look at the bottom, you can see pleomorphism, hyperchromatism, so that isn't normal. But you could see here that is normal. Now, carcinoma in situ is very, very important. It was in a lot of your past papers. The difference between dysplasia and carcinoma in situ is that dysplasia is only on the lower part of the epithelium, right? It didn't affect the top part yet. But when we come to carcinoma in situ, it's the entire thickness of the epithelium. You could see the abnormal cells at the top. You could see the mitotic activity where it's just supposed to be maturation there. Basement membrane is still intact, so it's in situ. It still hasn't crossed to become cancerous yet. Now, these are the difference, just to put that all in. You can see that it occurs on the lower part of the epithelium, still didn't get to the top yet. In contrast with carcinoma in situ, it's the whole thickness of the epithelium. Now, this was a question in SAQ given previously. It says, list 4 features of carcinoma in situ. Pleomorphism, different shapes and sizes, hyperchromatism, high abnormal mitotic figures, and loss of normal orientation and architecture. Now moving on to chondroma. Chondroma here, you could see a normal cartilage, and you could see here, this is also, it kind of looks normal, but there's just more cells. This is benign because it's well differentiated. Well differentiated meaning it still resembles the normal cells, the mature cells. Poorly differentiated, it doesn't look like the mature cell version. It's undifferentiated, you can call it. So this is chondroma. Now moving on to lipoma. Lipoma is a benign mesenchymal tumor. And as you can see here, the cells don't vary in size. They look normal. Other than the fact that there is a growth, the cells are normal, which means this is benign. The cells are well differentiated. Also in leiomyoma, cells do not vary in size. They look normal. They're well differentiated. So it is a benign mesenchymal tumor. Now, adenoma and thyroid adenoma, usually things that end with oma are benign, but that doesn't apply to everything. But usually, when they end with oma, they're benign. So this is a benign epithelial tumor. And you can see here that the cells are greater in number. They're not invading yet. They didn't cross the basement membrane. They still all look the same. They're just greater in number. They have the same morphology. This picture is a bit blurred, but you can see that there's more of the cell, but the morphology is still the same. Papilloma, also described as finger-like projections. You can see here it's a benign epithelial tumor, and you can see here that it's covered by stratified squamous epithelium, and there's this branching pattern. So this is how you know it's a papilloma. And here you can see on the side of the patient's mouth, and it's described as warty or cauliflower-like mass. Squamous cell carcinoma is malignant. When you see carcinoma, that's usually a malignant tumor. And how do you know it's squamous cell carcinoma? They usually have keratin pearls, as you can see here. They have neoplastic cells and stroma. So this is malignant. The most differentiating feature is the keratin pearls. Remember that. Now, differentiation. We mentioned it a little bit before when we were talking about the benign tumors, that well-differentiated means that it resembles the mature form. Here you can see squamous cell carcinoma, well-differentiated form of it though. So differentiation, how closely the cancer cell resembles the originated cell. The better differentiated, the better the prognosis and the more it behaves like normal squamous cells. And then you can see here, moderately differentiated, they start to look a bit more different than the other cells, and then poorly differentiated, worst prognosis. So this is the most aggressive and has a poor prognosis. Now, squamous cell carcinoma can also be seen macroscopically. Here we have squamous cell carcinoma on the dorsum of the hand. And also here, the squamous cell carcinoma arised from long-standing osteomyelitis, which is an infection of the bone. So from the chronic osteomyelitis, squamous cell carcinoma occurred. Moving on to adenocarcinoma, this was also mentioned in your past a lot. It has a classical feature, which is a knife-like infiltration, as you can see here. And adeno means gland, so it's a gland-forming tumor, and you can see the invasion, it's irregular. Also in the stomach, the gastric adenocarcinoma, you can see that the nuclei are enlarged and they're hyperchromatic. The pink fibrous part is usually the reactive fibrous stroma, which is typical of invasive adenocarcinomas. And you see these pale things here, that's mucin, because adenocarcinoma can either produce glands or mucin. So this is a malignant epithelial tumor. Here we have a past paper question. They asked, why is it so hard to cut into adenocarcinoma? Because of the fibroblast forming scar-like stroma. The scar-like, this is what they mean, okay? Now this is another example, but it's occurring in the thyroid. Again, we have that invading feature, the knife-like feature, so yeah. Now moving on to sarcomas, other sarcomas. We have a sarcoma in the retroperitoneum. It looks fleshy and bloody in appearance. And we also have embryono-rabidomyosarcoma, which are grape-like in appearance. Malignant tissue here, it looks like skeletal tissue kind of. It looks like peritoneal tissue because it arises in the peritoneum. Here, it looks like skeletal tissue. Moving on to osteosarcoma, which is a bulky mass in the cortex growing outward. This is the bone, and this is the osteosarcoma. It's easy to remember because osteo means bone. And when you see it microscopically, you can see this eosinophilic matrix, which is due to the malignant cells, which are the ones causing the cancer, producing osteoid, okay? That's why it looks a little bit more eosinophilic. They're a malignant mesenchymal tumor. Hamartoma, they're not a tumor, but they're a disorganized growth of normal tissue. What does that mean? So hamartomas are in the correct location, but they're a bit confused. They grow in the wrong orientation. So normally, in the lungs, in the trachea, مثلا, you would want the cartilage to be out and the smooth muscle to be inside. Hamartomas get a little bit confused. They do the opposite. So as you can see here, the cartilage is on the inside and the glands are on the outside. So wrong orientation of growth, but correct location. You can see here macroscopically, hamartoma, they're white. They kind of look like cartilage. A choriostoma is the opposite of hamartoma. They're normal tissue, and they're correct orientation, but they're in the wrong location. So مثلا pancreatic tissue in the stomach, or gastric tissue in Meckel's, or I remember there was one that was like glands in your ear, diverticulum or salivary glands in the ear. Moving on to metastasis, which means the spread of cancer elsewhere from its original location, so secondary to. Here you can see liver metastasis. There's multiple lesions, so they're all coming from cancer in different places. And here's a CT scan of a liver metastasis. The gray parts are the metastatic lesions. Lymphatic spread of cancer, which is most commonly seen in carcinomas. The only carcinomas that don't go through the lymphatic spread are follicular, renal, and hepatic, just because they're closer to the blood than other carcinomas. So you can see here, this is a lymph node, and you can see in the lymph node, there's glands from the adenocarcinoma. The glands are forming inside the lymph node. When you see hematogenous spread, which are usually sarcomas, so remember carcinomas, lymphatic, sarcomas, hematogenous. They usually spread through the portal vein or the vena cava in the lungs. And the lungs and the bone are the most common sites of metastasis. You can see the blood vessel here, the tumor emboli, and the malignant tumor. So the malignant tumor made its way to the blood and is spreading through the blood, hematogenous spread. Now, this is another way of the way tumors spread, seeding of a tumor. So when cells seed, like let's say they're in the same cavity, they seed and part of that cell goes into another organ in that cavity. So here you have peritoneal metastases. They kind of look like seeds to me. That's how I remember the picture. But I'm not sure that's the actual mechanism, but yes. Krukenberg tumor is metastasis to the ovary. And it's just this horrendous picture. Metastasis, cancer to the ovary. Now this is very important, osteolytic and osteoblastic metastasis. What's the difference? Now let's just look at the names first. Osteolytic, lytic means to break down. So this is, osteo means bones, lytic means break down, breaking down of the bone. So on X-ray you would see these empty spaces that look like the bone is being broken down. These are called lucencies in the X-ray. And the tumors that are usually causing this osteolytic metastasis produce either PTH or IL-1. Why PTH and IL-1? Because PTH increases bone resorption and IL-1 activates osteoclasts. And if you remember, osteoclasts cause bone resorption. So the patient usually presents with pathological fractures and hypercalcemia. Why hypercalcemia? Because the bone is being broken down. Osteoblastic metastasis, bone, again osteoblastic, making of the bone. So you could see on the radio, it's radiodense. It's not as translucent as this is. And it has high alkaline phosphatase. Why high alkaline phosphatase? Because it increases osteoblastic activity, increasing bone formation and remodeling. And it's normally seen with prostate cancer. Okay? Okay. Now moving on to the cancers, that like the ones that have the chromosomal changes. Retinoblastoma. Okay, before we get into the actual picture, let's recap how retinoblastoma happens. So normally you have this gene, RB, it binds to the elongation factor, preventing the elongation factor from activating cyclin D, which activates, which allows the cell to go from the G1 to the S phase. Okay, normally. But when you have the retinoblastoma gene, you don't have RB anymore. So elongation factor goes on to activate cyclin CDK4 and cyclin D. So now cyclin D can move the cell from G1 to the S phase. So now the cell keeps on proliferating. So that's how retinoblastoma occurs. Okay, just remember retinoblastoma, retino, the eye, and blastoma, cancer in the eye. Okay. Moving on to follicular lymphoma. Follicular lymphoma, as you can see here, let's just look at the macroscopic picture first. There's loss of polarity. What does that mean? Normally, in germinal tissue, the germinal centers are dark and the outside is pale, but here it's the opposite. The inside is light and the outside is darker. And there's also fat cell invasion. So that's how you know it's follicular lymphoma. How does follicular lymphoma occur? There's translocation of the BCL2 gene from chromosome 18 to chromosome 14. Why is this like a big problem? Because chromosome 14 has the heavy chains. Heavy chains are heavily upregulated, okay? Because you need to make a lot of them for the B cells, okay? But if BCL2 takes the place of the heavy chains that are usually upregulated in the B cells, that causes BCL2 to be upregulated. BCL2 is an anti-apoptotic protein. So it stops apoptosis. So the cells can't die. So they just stay there. Okay? So that's why it causes the cancer. Burkitt's lymphoma is very, very high yield. It's mentioned a lot in your past. Oh, by the way, I put this in green text because it wasn't passed. Burkitt's lymphoma is associated with EBV, or at least the endemic Burkitt's lymphoma, the African one. It's associated with EBV, and it commonly involves the jaw and the facial bones. And when you see it microscopically, it has a starry sky appearance. This is very, very important and very high yield. It occurs due to translocation between chromosomes 8 and 14. So chromosome 8 has the CMYC gene, and this gene is going to translocate with the heavy chain again. And the heavy chain is normally very upregulated. When the translocation happens, the CMYC is overexpressed, so it causes increased mitosis and therefore causes Burkitt's lymphoma. Now, Kaposi sarcoma is caused by human herpes simplex virus. This is very, very high yield, and I think this is an SAQ. I just forgot to put it in green. And it's most commonly seen in AIDS patients, and it's usually seen in the skin. So you see these scars in Kaposi sarcoma. Cachexia is due to loss of body fat and muscle wasting due to the release of TNF alpha. So this is just a picture that they'll show you. I haven't seen any questions about this, but I'll just add it here for the sake of completion. Bone marrow metastasis is so important because it causes a lot of anemias. One of the most important anemias that it causes is anemia of chronic disease. And this was also mentioned in past. I just forgot to highlight it in green. So yes, you can see here bone marrow metastasis occurring. This is mature bone, and metastasis of a cancer is invading the bone. Now, finally, moving on to the pharmacology lab, we're almost there. The pharmacology lab, basically this, you don't need to know this that much. This is just for the sake of understanding. Once you get to the actual part, you're probably gonna forget this part. But anyway, so this is called an organ bath experiment, okay? So here you have the organ bath and you have a reservoir. You put a tissue in the organ bath, okay? And you add the agonist to the organ bath and you record the contraction that occurs with this agonist, okay? And then you want to remove the concentration that you just added, right? So you're going to use this reservoir with Krebs solution to wash out the agonist and try out another drug, okay? Okay, just keep that in mind. Don't read the text right now. This is how it looks like in a computer system, and you have the default settings. So this is where you add the agonist and the antagonist, and this is where you use the reservoir to flush the drugs out of the tissue that you're testing. Now let's talk about the first drug that they're going to use, which is acetylcholine, which is an agonist, okay? So here we have a table of the concentration that we're going to use and the volume of the concentration that we're going to use, okay? So you can see that with increasing concentration, we get an increasing response. We keep the volume the same as like a control, right? But when we see that, we can see that as you increase the concentration, you increase the response, right? Right, so now we want to plot this on a graph. We have here the force, the maximum response that we got, and the concentration of how much we added. At the beginning, the response is 0 because the concentration really didn't help that much. It was literally negative 0.1. But as we add more, the concentration increases and response increases until you get to this plateau phase. When you see the plateau phase, you know khalas. The efficiency, this is the efficacy of the drug. It reached maximum force. Now, when we have all of this, we want to calculate the EC50. What's the EC50? It's the concentration of the drug that evokes half of the maximal response. What was our maximal response? 14.2. So 14.2 divided by 2 is 7.1. So we'll go back to our graph. 7.1 was the maximal response. We look at what concentration that was, negative 7.4. So that's our concentration where we get half the maximal response. Now we convert this to anti-log, which the only thing you have to do is just put 10 to the power of negative 7.4, and then you get the concentration in M. So this is the EC50 for acetylcholine. Now, response to the antagonist. So now we're adding the antagonist with the agonist. Remember the reservoir we talked about, the one with the Krebs solution that washes it out? This time we're going to add the antagonist. And what are we going to do? We're going to be adding increasing concentrations of the agonist, okay? And we're going to wash it out every single time with the antagonist. So we want to see what concentration would cause the most response with an antagonist present. So as you can see here, it took a while to get a response as the other one. And the other one, I think at -3, we got 14 point, me check. -3, we got 14.2. Here we got 14.1. Not as big as a difference, but as you can see, and you get the idea, you need more of that drug to cause an increased response. So in the graph, again, when we see the graph, you could see that when we added the antagonist, the graph changed. Remember, this is our original one without the antagonist. But with the antagonist, the graph, what happened to the graph? It shifted to the right. The slope relationship didn't change. It's just a parallel shift. And the maximum response didn't change at all. Like you could see here, the maximum response didn't change. But the EC50 has changed. Let's take a closer look. ECF50 last time, okay, was half the response. صح? The maximum response was 14, right? So let's go to 7. It was here, صح? 7, when you correspond it here, it was at 7, right? When you look at where we added the antagonist, it's at 5. So we lost 2 log units. We moved 2 log units, which indicates that the antagonist makes the agonist slower or less effective. So for you to get the same response, you need 100 times the dose to get the same response. Okay? Okay. Now, we talked about it only being a parallel shift, not like a big shift. It didn't change the slope relationship, right? This is seen in competitive antagonism. Okay, this is very important because I saw it in your past papers. What would we see if it's non-competitive antagonism? We would see a change here in efficacy. You see how this one just shifted to the right in drug A and you add a competitive antagonist shifted to the right? This one went like this. The efficacy went lower. So you need higher doses. Even if you get a higher dose, you wouldn't be able to get a greater response. Okay? Okay. Now, lastly, we have acetylcholine and histamine. Now, acetylcholine, we want our aim for this experiment, we want them to have the similar response or somewhat of a response, okay? We're going to add a selective competitive reversible antagonist to histamine to see how would this affect the muscle contraction, okay? So when you see here, before we added everything, their maximal response was similar. This is acetylcholine, this is histamine. When we added mepyramine, which is the selective competitive reversible antagonist, histamine completely disappeared, completely. And then when it was gone and it recovered, it went back to its place. Now this is also important because I also saw in your past. This is all of it together. This is when acetylcholine, histamine together, then histamine just disappears and then it's back again when we removed its antagonist. And that's it for my part of the session. Thank you so much, everyone, and please scan the QR code for your feedback. And if you have any questions, here's my contact information and here's Feras' contact information. Have a nice day and good luck on your exam.